Hi, I'm Dr. Nicole Rogers, a board-certified dermatologist and hair transplant surgeon here in Metairie, Louisiana. And today I'm going to talk a little bit about pain control during hair transplant surgery, because we have a lot of patients who have this perception that is a very painful procedure. And I just want to reassure you that that is not the case. And I'm going to walk you through exactly what to expect on the day of your procedure. So first of all, we do start fairly early, usually around 6:30, 7 o'clock, usually in the morning. And we encourage you to have a nice breakfast. That way this will help metabolize any medicines that we give you. We do take a minute just to review pre-op instructions, post-op instructions, answer any last-minute questions that you may have about the procedure. We like to check vital signs. We like to get you changed into a gown, take down your emergency contact information, and then put back on those markings in the photo room, which is actually where I'm sitting right now. As my nurses will tell you, probably the most important question is what kind of music you like, because we generally put our Pandora station on something that our patients are familiar with and find to be nice and relaxing. The next step is to prepare your cocktail. I generally like to offer people a little combination of short-acting benzos such as lorazepam with maybe a little longer-acting benzo such as diazepam, and that just keeps you on a nice, relaxed place all afternoon. If you let me, I also love giving a little bit of meperidine or Demerol. And the other thing people like is some Benadryl. It's also very sleep-inducing. Now, if you're someone who doesn't like being on prescription medications or taking stronger sedatives, plenty of people will opt to just take a little bit of Tylenol or even combine some Tylenol with some Benadryl. But basically, we want you to be in a nice, relaxed place. The next step is to get our patients comfortable. So we get the medicine on board, we pick out the music that you like, and then we get you situated in the procedure room. Usually face down is how we do the initial harvesting, but we have a lot of different pillows and we have a lot of different shapes of pillows. So we can prop up your feet, we can take the pressure off your back, we can turn you on your side, whatever we need to do in order to maximize your comfort for the graft harvesting process. Hair surgery in most clinics is done under local anesthesia, so our patients are awake but relaxed because of the medicine that we just discussed. I like having my patients a little bit awake because that way, if I need you to turn this way or that way, you can follow instructions. There's also generally fewer risk of complications from general anesthesia. For some patients, they may be very slow metabolizers. They may not need that much local anesthesia. Others may be more rapid metabolizers, but you can give us that feedback as necessary. And there's generally very low risk of toxicity when you're just using local anesthesia. Now, before we even start using any needles to inject, we have different things we can use to trick the skin and the nerve endings. First, we have to cleanse the skin, obviously, with some antiseptics, but then we can use things like this BioFreeze, which is one of my favorites. It just has a little bit of menthol, but it's enough that it kind of tricks the nerve endings so everything feels kind of cool. I also love incorporating massage into the numbing process. We use this device, it's called the thumper. Usually one of my nurses will come in the room, so while I'm injecting the local anesthetic, one of my team members is using that little thumper to trick and distract our patient. So here's a patient undergoing numbing. This is during a strip harvest. You can see just very slowly going across the edge. When we're doing the numbing, we're using very mild 1% to begin with, and we buffer it. I'll talk about that in a minute. We want to just go very slowly and very carefully. There's no rush, no rushing. You can see here, this is positioning for FUE donor harvesting. And again, we're just having the patients position first. They're looking to the right. We start harvesting on that right side, and then they slowly turn so they're looking down, and then they're looking to the left. So we're basically working our way around the back of the head during the FUE harvesting process. And we try to get people comfortable using, this is a little custom designed sling that we had put together so that if we don't have room underneath for people to put their hands on a stool, they can just hang them right in that sling there. This looks kind of probably like a busy, scary slide with all this, anesthesia, but basically we don't usually even use half of this for most of our cases. This is the 1% that we start off with, and we move to the 2%. Then I like using longer acting anesthesia. And then this yellow anesthesia has what's called Kenalog or triamcinolone that helps prevent forehead swelling. But you can see I have my own little mini massager that I'm keeping in one hand while I'm injecting lidocaine. And then we use the tiniest needles that they make. These are just little 30 gauge needles. So again, we're just making the tiniest little breaks in the skin in order to inject that anesthesia locally. For those of you who are familiar to the New Orleans area, you've probably heard of d'auberge cake. And what I love about d'auberge cake is it has lots and lots and lots of layers, which is how we do our anesthesia. So first we start with a nice 1% lidocaine. Again, we're buffering it with sodium bicarb. This makes a big difference. It takes the sting out of that initial numbing. Then we come back with a 2% lidocaine. Then we come back with our longer acting, either Marcaine or ropivacaine. As we're harvesting the donor area, sometimes we'll actually use a little tumescent saline. What that does is it just helps lift up that tissue from the underlying vasculature. So it just helps kind of reduce the incidence of bleeding, and it also helps my team a little bit because it kind of pushes apart those hair follicles from each other, so it's easier for them to be separated under the microscope. This was an interesting publication that I came across recently, and it really changed how I approach the numbing process. Originally, for a long time, we would use a 9-to-1 ratio of lidocaine to bicarb. But this publication suggested that using a higher ratio of more bicarb to lidocaine could make it an even less painful process. So we like to incorporate this as well. For those of you, maybe physicians who are listening, this is exactly how we do it. My nurse draws up 2.25 mLs of lidocaine, and then we add the rest in sodium bicarb. And then right before I inject it, I change to a fresh 30 or 32 gauge needle, 33 gauge needle. And the thing is, we like to change those needles frequently because they do dull out. So, we're going to basically just very lightly be injecting that anesthesia. The most important thing of this whole thing is giving anesthesia time to work. So, if it seems like during the process I'm stalling for the time, I'm talking to you, I'm checking on something else, it's because I'm actually just letting the anesthesia do its job. We're constantly monitoring our patients, okay? If we see that you're clenching your fists or grimacing, we're going to stop and we're going to be constantly asking you, are you feeling that? Are you having any kind of discomfort? The last thing we want is for you to say, are we almost done yet? Am I supposed to feel this? We want to be one step ahead of you, or even 2 or 3 steps ahead of you the entire procedure. These are just a couple little tricks. These are what we call nerve blocks. Sometimes we do nerve blocks in the occipital nerve area. This is a technique to locate that nerve. This is actually a patient of mine who allowed us to demonstrate using a Doppler. So when you hear the occipital artery, that basically tells us where the occipital nerve is located. And then what we can do is mark that, and then we can go back in and inject some lidocaine into that area. These longer acting anesthetics are extremely important. They're extremely helpful because they can last all day. The other nice thing about it is that it reduces the fluid volume that we're having to inject into the grafted area. So ultimately what that can do is decrease the risk of forehead swelling. For a long time, we just used this 0.25% Marcaine. After COVID, there were kind of some supply issues, or during COVID. So we ended up moving to the 0.75, and we have not had any issues with it, and patients actually love it because it lasts even longer. Ropivacaine is another interesting molecule that, we've incorporated for longer acting anesthesia. Now we have to talk about numbing the area to be grafted. This is what we call a ring block. So we're going basically all the way around the front. And generally people tell us this is easier than numbing the donor area. So I think part of it is because they're more comfortable, because they're turned over, they're facing the front, they have a little bit more control over their environment. But basically we do the exact same thing. So we're layering that anesthesia, starting with 1%, going to 2%, and then we're going to that longer acting anesthetic. Importantly, we do incorporate triamcinolone in that. That helps prevent forehead swelling later. Now, once I start making recipient sites, and we let it sit, but if I start making sites here and patients tell me they feel anything, I stop and I actually do what's called a little nerve block right in that inferior medial eyebrow. And what that does is it blocks these two big nerves that are coming out on either side. And usually once we do that, patients tell us they don't feel anything, okay? But not everybody needs this block. This is just something we do. This is sort of a game day decision if we need to go to it. Forehead swelling, we're trying to prevent that by minimizing the amount of fluid that is going into the frontal scalp. We do incorporate that Kenalog or triamcinolone into our numbing solution. We prescribe some prednisone, so our patients are going to start that the morning after surgery, and then we'll actually send you with a little ice pack. If you need to ice the forehead, you can. Just make sure it doesn't get stuck to the grafts. Okay, this is very important. We're going to send you home with a go bag that has all the things that you need to take care of the grafts. You're going to get some saline spray, which has that liposomal ATP, which is energy for your grafts. So this is important. We want you to spray the grafts 3 to 5 times per day. Most people don't complain of pain in the grafted area. If anything, they tell us it still feels kind of numb for several days after the surgery. Start that prednisone. Most of the patients are fine with either ibuprofen or Tylenol, but we do give you some prescription pain medicine. For our out-of-town patients, usually it's Toradol or Ketorolac. We'll give you essentially whatever you feel like you need, but very few people even use all of the Norco that we give them. We do prescribe some topical mupirocin ointment to that donor area, and then we also give you some triamcinolone. Patients who have the FUE donor harvesting sometimes will describe almost like a brush burn sensation, and so we'll actually talk about ways that you can kind of deal with that if that develops. It's usually in the second week, not so much the first week, if you notice that. And this is just some feedback, from our patients. Generally, people tell us it hurts a lot less than they expected. They say the whole experience was much easier than they thought that it would be. Some people, they say they don't really even remember it. Maybe they just remember when we woke them up for lunch. So that's always kind of nice. And then they really make our day when they say, "Can I come back next week?" Because that's the sign of a happy patient. Thank you so much for watching, and I hope this has been helpful.